All right, thanks, Tim. So welcome, folks. Hopefully people will join up over the next couple of minutes. We've got an hour, and we've got a good agenda for you all. We're gonna obviously the bulk of the evening is going to be spent with Steve chatting with us about the New York Health Act, which is within reach, we think, maybe this year, hopefully. There'll be plenty of time for Q&A, question and answer. There's a lot of questions. A lot of people have good questions that they've brought up over the weeks. So we're excited to hear from you what you're wondering about with the Healthcare Act and what it's all about. And then after that, Rebecca Street, one of the members of the steering committee, will talk to us about a pledge letter that she wrote, a pledge letter that ideally, I guess, goes to the legislators to say, I pledge my support. And we get mileage out of that. We get people to see that, to see who is pledging their support. Hi, Barbara Pichler.
Is she there?
Yeah, she's on mute. She's a friend of ours from Hastings from years ago.
Hey, Barbara.
Anyway.
Oh, hi. Done very good. Good to see you.
Welcome to Hastings Reunion 101.
Right. Yeah.
All right, so let's get started. I'll hand it over to Julie, and she's going to introduce Dr. Steve for us.
Yes, always my pleasure. Many of you know Dr. Steve. Anywhere that anybody's organizing about anything related to health justice, he is there. So Dr. Steve Auerbach grew up in New York City. He received his MD degree and MPH, Masters of Public Health, from Columbia University, did a residency in pediatrics at UCLA, and then started a career as a medical epidemiologist with the US Public Health Service, first with the CDC in Atlanta, then overseas, then with the Health Resources and Services Administration, which some of you know as HRSA, back in New York. And then he's been a long time, as many of you know, health justice and single payer supporter. He's a member of Physicians for National Health Program. And having reached which I didn't know, but the US Public Health Service mandatory 30-year retirement in June 2019. He's now an activist and volunteer for single payer and all sorts of social justice and health justice activities. So that's why we see him so much, because he had to retire. So we're happy from that point of view. And he also is our new secretary of the PNHP New York Metro chapter. So Steve, you're on. Thank you for joining us.
Sure. So I was asked to speak about the state-based Universal Healthcare Act, which is a federal piece of legislation that's being promoted, particularly by a group out there called One Payer States, which I think we should become much more involved in, to the extent that we are supporters of a state-based single payer, the New York Health Act. We have colleagues working in parallel across the country. So I'm going to bring up my slides because, you know, can't be a single payer activist without slides, especially if you're from the doctor side of the movement. Can people see the slides clearly?
Yep.
All righty. So I'm here to talk about state-based universal health care in general, but more specifically about a particular piece of legislation that's been proposed and is carried by Ro Khanna in the House and Senator Markey in the Senate, called the State-Based Universal Health Care Act, or SBUCHA, or however you want to abbreviate that. And I should mention that I just recently was asked to be on the board of directors of One Payer States. It's one of those you show up and they ask you to do stuff. I don't know how many of you are familiar with this other group called National Single Payer. So there's this other group called National Single Payer. It wouldn't be the left if we didn't have a nice circular firing squad going. So there's a group called National Single Payer that objects on principle to advocacy for state-based single payer for a variety of reasons, and I'm not going to speak for them other than to say I disagree. So I'm sort of a big tent guy and a two-track person. I'm happy to work for national single payer. You know, the fact that we have roughly a dozen co-signers in the Senate, co-sponsors in the Senate, and you need 60 to do anything, suggests we may not be quite as far along there as we might be, say, with the New York Health Act, with a nominal majority in both houses of the state legislature. We've certainly got colleagues in Oregon and Washington and California and Colorado and Minnesota who think they're at various real stages along the way too. I can certainly make a political case and a historical case, but mostly a political case that we're far more likely to pass a state-based bill, and that actually passing a state-based bill and showing it works would be a big driver to national, especially if it's a big state and it pulls a lot of money and dollars away from the insurance companies. You know, if you get California, New York, then everything else kind of collapses, is one argument. So without further ado, and you may see the red, white, and blue theme here, because we're all patriots. We all want a better United States. We all want something that's better for all the people living in the United States. So what is state-based universal health care? Well, it's the New York Health Act, right? So everywhere where I say state-based universal health care, you can just plug into your head New York Health Act. But basically, it's a state-based single payer to achieve universal comprehensive healthcare coverage for everybody. That's affordable for everybody. Preferably with things like not only universal eligibility for all residents in the state, regardless of their immigration status, but also paid for progressively, covers all persons, but also all providers, comprehensive medical, dental, mental health, is able to negotiate rates for services, rates for drugs, using monopsony power, low or no cost sharing for patients, along with the comprehensive benefits. Of course, here in New York and most other bills that I'm aware of, we've added long-term care. And part of what makes it single payer is, you know, we always use it as a slogan, but it's actually an economic term in this sense of limiting health insurers to not be allowed to offer duplicate coverage, so that it's an everybody in and nobody out. Everybody's paying in, nobody's excluded, everybody has it all the time, regardless of changes in life circumstances. All the doctors and hospitals take it. And yay. So we've had the movement for the New York Health Act here, and I don't know how aware people are of what's been going on in other states. I know Vermont was in the news when they passed their bill with a rollout mechanism that was pre-designed deliberately to fail, in my opinion. We know that Colorado, I think, was the last state that tried to do a referendum. Was it Colorado or Minnesota? Now I'm confused. Tried to do a referendum, which basically was a bunch of outsiders that hadn't worked on single payer, not talking to the people who had been working on single payer, and lo and behold, it failed. So lots of excuses why we don't get single payer at the state level, but we keep trying. And I just want to point out, there was an article in Health Affairs that addresses some of the issues, and the full link is there. And many states, in addition to New York, have it, and one-payer states has actually collected some brief summaries over the years of what's going on in each individual state, including ours. Ours was last updated, I think, in 2022 by some combination of Len Rodberg and locking on our buddy who always partners with Len. on stuff.
Henry.
Henry Moss, yes. So in the past, Henry Moss and Len Rodberg have been a bit involved with one-payer states, but they've stepped back from it. I've become more involved, and they would really welcome some folks from NIPAN. It's not a PNHP group. It's really much more a not necessarily physicians activist group, more on the healthcare now model, if you will, than the PNHP model. And so would really welcome more folks from NIPAN and folks who are involved with the campaign for New York Health to get involved with one-payer states. According to one-payer states, this is a list of states that have been working on state-based single payer. Some reason their list says 19, and then when you count it up, it's 22. So I think the real answer is it's in flux in terms of how active any given state is at any given point in time in passing single payer. You know, I look at Florida there, and you know, I somehow have my doubts given the current politics of Florida. But you never know. I mean, they passed a referendum increasing minimum wage to $15. So, you know, the people want things that the state ledge blocks. So what, however, are the legitimate concerns about being able to pass and implement a state-based single payer? And forgive me, I've just put these slides together very quickly. You know, I'm sort of getting myself up to speed on Sabuca and all that. Looks like we have another person in the waiting room there. So forgive this text heavy and reading from text, but it's going to go quickly and then we'll be able to have a conversation about it. So one of the issues is federal waivers. If you're going to fund a state-based program like the New York Health Act, you need to be able to capture somehow the federal funding that is coming into a state already for various state, federal, or just straight up federal programs. So you need to capture Medicare, including the Medicare disadvantage piece. So you need to be able to capture A, B, and C of Medicare. You need to capture Medicaid. You need to capture CHIP, and somehow integrate those fundings streams, as well as things like the ACA tax credits. Hi, Peter. ACA tax credits, our tax expert here, on getting that into the state funding for the state-based program. So the good news is that there are already numerous examples out there of Medicaid and CHIP waivers. And while technically they're not waivers, they kind of function as waivers, various Medicare demonstration projects. The most notorious of which, from our perspective, is ACO REACH, which is being done as a Medicare quote-unquote demonstration project. And perhaps the most famous, I think, positive one is Maryland getting the permission to do their uniform pricing under an all-payer model from years and years at the hospitals, and then recently doing it for the physicians as well as several states that have begun to experiment with things like various partial programs of global budgeting. So a lot of things that single payer advocates have pushed for have been experimentally done in a variety of other states. Maryland, Massachusetts, Pennsylvania all have been playing around with some global budgeting models. Some of this was emergency response to hospital funding crises during COVID. And the ACA, there's been these 1115 waivers, and then also the 1332 waivers for innovation and demonstration projects. Now, there's a couple of problems with saying, oh, well, there's other waivers out there, and therefore our waiver will get approved. So the biggest bad news is whenever single payer passes and looks like it's going to really happen, there are going to be court challenges, right? The insurance companies and their friends and relatives and acquaintances will, sue in court to block it. And no matter how logical or what factual case we make for why waivers are okay, and why the New York Health Act should meet waiver requirements, you never know what a court's going to do. And we've seen how courts get packed with some real troglodytes. And at the very least, the fact that there's at least an argument to be made against the waiver means it won't get summarily dismissed, and it could at least drag it out. And even if you win, it's, you know, it drags out and harms or even kills the implementation just with the delays. And that's even if you win. And there's no guarantee that one wins. So that's an issue in terms of the waivers. So there's another issue that's sometimes lumped together with the waivers question. It's a little different. It's a specific law, the Employee Retirement Income Security Act, or RISA, passed in '74 to try and create a degree of national uniformity and security for pensions and health and other benefits covered by employers. And basically what it says is that the federal government has the priority in governing such plans. So if the federal government has a law or regulation impacting one of these kinds of things, and in particular, employer-based health insurance, that is all a matter of employer-based benefit programs. If the federal government has regulation or legislation on such an employer-based benefit plan, states can't preempt it. Now, it's possible that this was meant initially, I hope, that it was going to not allow states to race to the bottom in deregulating or putting in rules that limited benefits in order, just like they cut taxes and deregulate to attract businesses to come to the states, that this was to maybe help set a ceiling, set a floor, rather. In any case, ERISA is sort of a federal preemption over state regulation of any sort of employer benefit plan. So the question is, well, how does ERISA impact a state-based single payer plan, since in theory, what we're doing de facto, don't quote me on this, is we are, among other things, getting rid of employer-based health insurance plans as individual fragmented through private health insurance plans. And the good news is, well, we're actually not saying anything about them. Employers can still do whatever the heck they want in terms of their health benefit package to their employees. They still have to pay the tax for the New York Health Act. But we, the state of New York, are not telling them they can't also continue to provide the program that they've been providing. Why they would want to, obviously, if we're taxing them on the one hand, and on the other hand, providing their employees a even better package. They probably won't want to, but we're not regulating them. The counter to that is that the language isn't just regulate. There's also a phrase in there about otherwise impact. And so we could say, well, we're not regulating the employer plan. We're just making it moot by, offering everybody a better plan. Plus, we're taxing the employers, so clearly they're going to want to drop paying for it. And isn't that an impact, even if it's not directly regulating them? So, we can argue, well, the employers are still free to maintain or not maintain the programs. We're not regulating them, but we're certainly impacting them by both taxing the employer and offering something better. And again, the bad news is inevitably there's going to be court challenges, and we just never know how the courts are going to rule. Now, as I showed on the previous page, the New York Campaign for New York Health, and again, I think this is a Henry Moss and Len Rodberg special, have offered some FAQ sheets on both the ERISA question and the waivers question. And I just want to point out that OPS has a much more detailed and lengthy piece on ERISA as well. So because of these concerns around waivers and ERISA, there's been a movement in the state-based single-payer community to have federal legislation that says waivers and ERISA waiver will be granted. Medicare, Medicaid, CHIP, ACA, and ERISA waivers will be given to any state that implements a state-based plan like the New York Health Act. And so it's basically to modify the existing laws around ERISA, a federal law, and the existing laws around waivers for Medicare, Medicaid, and CHIP, and put in, if you will, a super waiver that says any state that wants to do New York Health Act will be given the waivers that they need automatically. It's guaranteed. It's a change in the existing law so that presumptively waivers are given. That means, and again, we shouldn't be under any illusion that there won't be lawsuits the moment anything passes. But it does make it harder for them to win any of those lawsuits on the basis of federal waivers for Medicare, Medicaid, ACA, or CHIP, and ERISA. And it even makes it likely that they wouldn't even be able to drag it out, because with Subucha in place, they're likely to be summarily dismissed because they are prima facie wrong. So anybody can sue, but they're more likely to get summarily dismissed if Subucha's in there. And basically what it says is that it allows states explicitly to set up a single publicly funded entity to pay providers covered healthcare for state residents, and that the waivers needed to subsume Medicare, Medicaid, CHIP, ACA taxes, and ERISA are default essentially given. There is protection, and this is one of the things that was being debated in this back and forth that occurred in Common Dreams. It is explicit in the Subucha legislation that any proposal that is going to get these waivers must be at least as comprehensible and affordable, with the cost-sharing protections at least as strong as the federal program for which the residents would otherwise be eligible. In other words, you can't do this to do a worse Medicare for people who are getting Medicare already, or a worse Medicaid for people who are getting Medicaid already. Has to be at least as good or better. So one of the counterpoints to those that were objecting to Subucha, that it was somehow going to kill Medicare as is, which I think is just prima facie, I just want to say prima facie false and frankly a bad faith argument. But one of the counters to it is, hello folks, there's already waivers out there. So there's 1115 and 1332 for various demonstrations and innovations. And ACA calls for a variety of different further demonstrations and innovations than there had been before. And states are already using the waiver process. We would argue that the current waiver process, the current waivers that are allowed, are both too loose and they don't go far enough. So on the one hand, they're too loose because they in fact do allow states to choose to do worse. And the classic example in recent years on this has been work requirements for Medicaid. You know, we're having the fight in New York over expanding Medicaid to, or at least the central plan, to all persons regardless of immigration status. And that's under a 1332 waiver. We see experimentation with Medicare, with bad things like ACO REACH under the same innovation rhetoric that the ACA put into place. So there's all kinds of allowable doing worse as opposed to doing better that's already out there. And Subucha actually specifically says this can only be used for going in the other direction. So, and it creates section 1335. So these are all various amendments to existing legislation going back all the way, frankly, to pre-World War I security, Social Security legislation. The mandates that the states have to guarantee that they'll achieve at least 95% coverage of residents within 5 years, that the plan's benefits have to be equal or greater to the beneficiaries, what they would be eligible for. So again, if somebody was eligible for Medicare, it has to be as good or better than Medicare. If they were already in Medicaid eligible or CHIP eligible, it has to be as good or better. It also allows groups to come together for joint plans. This is especially relevant for smaller states when you've got several small states that might be adjacent. So Vermont and New Hampshire, for example, could come together and do a joint plan with Maine. It explicitly allows integration of the Medicare funds into a state plan, which is not technically in the waivers, although Maryland has been able to modify Medicare for a variety of purposes. It directly, explicitly gives a RISA waiver, which has not existed before. And the current process basically leaves everything in the hands of the Secretary of Health and Human Services. And it's thought that by having a panel that would review waivers that would be required to include healthcare provider groups and patient advocate groups, as well as political leaders from both sides, regardless of who's president or who's controlling Congress, that having that panel is somehow a protective thing. And again, if you want a more official FAQ sheet, the link is there. So what are our next steps? Folks can sign up for becoming active in one-payer states. I've got a variety of links here. There are 2 current petitions that are out. There's a petition, which is basically a petition to Congress to pass SABUCHA. There's a separate petition just to the Senate to ask your senators or our senators to sign on to the Markey SABUCHA bill, which is new. There hadn't been a companion bill in the Senate until 2024. So before that, there had only been a House bill. And as I said, Chuck and Michael and others who have been longstanding involved with one-payer states are really, really looking for somebody who can pick up the ball and promote SABUCHA within New York State, just as they already have folks doing in California and Oregon and Washington and some of the other states. So I'm going to leave it there. I sent out the links here. I think I should, let's drop the screen sharing. So
If you'll send us the links, we'll send them out tomorrow to everybody.
Yes, they are in the PowerPoint that I sent out. I can also drop them as chat into the chats here. But I think, they're the last slide in the slides that I sent to everybody tonight. So with that, I'm going to pause and see where we are in terms of yay, nay, or
So I could jump in, Steve. Thank you. Thank you very much for doing this. If there are any questions, you can put them in the chat or just raise your hand using the icon. I guess I'll lead off with a question. I've got 2 questions. One is a little more esoteric, but I'm not that familiar with the state-based act. But can you sort of clarify the relationship of the effort that the state-based act is pursuing and the effort that the New York State Health Act is pursuing? I mean, we talk about for Medicare, for example. I think Dick Godfrey, one of the early sponsors, talked about the New York Health Act wrapping itself around Medicare and Medicaid and filling in the blanks with such things as vision, dental, hearing, long-term care. Can you
But we
expand
also
on that a
need to
little bit?
capture the Medicare funding, A and B. We need to kind of capture that funding to pay for the New York Health Act, right? And the concept essentially currently is that in effect, New York State would be the biller to federal Medicare. It would take care of the patients, and we in effect would be the intermediary biller to capture the federal money. What if a party out there says, no, that's illegal, you can't do that? Or, you know, there was that whole imbroglio over the language that was in the New York Health Act in the previous version, referring to Medicare Advantage, which was widely misunderstood. So I think the language was in there for a very good reason, which was that we wanted to make New York State able to capture Medicare Part C money. And the only way to do that was to basically make New York State a Medicare Advantage company. So we were going to be a Medicare Part A company. We were going to be a Medicare Part B company. We were going to be a Medicare Part C company. And it was simply to capture the fact that Medicare C gets extra money. And we want it. We don't want it to go into Aetna. But we weren't going to create narrow networks. It was just a way of capturing that stream of funding. So what Sabucha does is it allows the New York Health Act to go forward as envisioned without having to worry about the waivers issue or the ERISA issue. To whatever extent you were worried about the federal waivers for Medicare, Medicaid, CHIP, ACA, whatever I'm leaving out, plus ERISA, whatever extent you were worried about it, this was to put that worries relatively to rest. We're going to create a new waiver system that says you want to do more, you can do more, and you got the waivers more or less automatically, as long as you're doing at least the same, if not more. Now, there are some limits to Sabucha as currently written. Nobody is saying it's a perfect bill, very much open to revisions. One of the things that, for example, Dick Gottfried mentioned as a concern was, in theory, current Medicaid recipients, the doctors and hospitals taking care of current Medicaid recipients could be paid at current Medicaid rates, and the current Medicare recipients, or if you're Medicare eligible under federal, then New York Health Act would reimburse as Medicare, and if you were eligible for Medicaid as Medicaid. In others, it could be still fragmented pools in the sense of we're only going to pay doctors who see Medicaid patients the same lousy Medicaid rate. It isn't clear in the Sabucha bill because the language is you have to do at least as good as the current program. It didn't require you to really do a single payer, everybody gets treated the same kind of a thing. Now, part of that was deliberate in the sense that they wanted to not directly use the word single payer in the bill because they wanted to pass. And they didn't want to run into everybody who's currently opposed in the federal Congress to oppose this. You know, we would make a states' rights argument to attract Republicans. You know, we would make a states' rights argument to say, well, let's free up the states to be the laboratories of democracy. And you and I know we want it to be like, you know, Saskatoon in Canada. You know, and the anti-loophole is that they can't use it to do a race to the bottom. They can only use it to achieve the same or better. Another objection is that 95% in 5 years, 10 states have already done better than 95% in terms of coverage. So to have as your minimum requirement 95% in 10 years did, from a single payer advocacy point of view, was pretty crummy, right? We want 100% in, in next year. But again, it was a compromise, given how many states are well below 95%. It was a compromise. Yes, Charlie, thank you. TRICARE, FEHB, and Indian Health, Tribal, all get the same kinds of waivers that they get in state single payer bills as well. Gene, okay, I'm just looking at the stack there, Gene, and then Ting.
Yeah, two questions. First of all, is this thing subject to the filibuster?
It's considered to be, there's specific language in it that states that it is not, but does not affect the budget, the federal budget. So I forget which, I always get it backwards in terms of, are you subject to the filibuster or not the filibuster? But in terms of all of those pledges that like Pelosi and the others kept making about being deficit neutral or budget neutral, whatever, it's budget neutral, deficit neutral. If that answers the question, and that's explicitly in the bill.
Okay, I'm not sure. The other question was you talked about contiguous states uniting. Is there any effort for having states that are not necessarily contiguous? The map that you showed had
Right.
a lot of different places uniting on setting pharmaceutical prices.
Sure. So, well, on a specific thing like that, I can't speak, but I was out of line when I said that it requires it to be contiguous. That was my additional ad lib. So it allows states to work together, period. There's nothing about contiguity in the bill. It just happens that I was having a conversation with somebody in New Hampshire who was talking about how they've had discussions with Vermont and Maine. So in my head, it meant contiguous. And in my head, I was also thinking, oh, we should learn more about what's going on in New Jersey and Connecticut and Pennsylvania and the other adjacents for us. But no, it's not in the law that it has to be a contiguous state, any states. So yeah, so in terms of negotiating drug prices, California and New York could get together and
be pretty powerful.
yeah.
Right.
Ting.
Thank you. Ting,
Thanks,
then
Steve. This
I'll
is
pick
great.
up-
I particularly am enjoying the fact that you're sitting in the assembly meeting room while you're doing this. So question, what is the state of passing this in the House and the Senate? And where's the objection mostly coming from?
It's nowhere's close. It's relatively new. I would say it's nowhere's close, but it hasn't been strongly advocated for until this past year. So, I really don't think there's been any action on it until, frankly, I was completely uninterested in working on it until there was a Senate companion bill, right? If they couldn't get a Senate companion bill, to my point of view, there was no point in doing anything. So Markey's got a companion bill and, there's a half a dozen or so folks on it already. It's run into a little bit of the circular firing squad issue of the people that support national single payer is the only way to go, period, full stop, and are opposed to any state-based efforts, have been trying to torpedo it as part of that effort. I mean, in all honesty, there are specific things in the bill that can be improved. I don't think that the Common Dreams article, frankly, was a good faith critique of let's make the bill better. It was state-based single payer is evil, and the only way to go is national single payer, period. So if you're opposed to state-based single payer, you're opposed to this.
Charlie? You're muted. You're muted.
Yeah, thank you. So I just had some comments related to some of the things that Steve said. One is that there is an effort to create what I would say is a multi-state public pharmacy benefit manager. So to sort of pool drug purchasing. And I would argue that kind of leading the effort is ArrayRx, which is an entity that was set up in Oregon and Washington. And so if people are interested in that, I would love to get some New York people interested in talking about potentially joining with ArrayRx. So Connecticut and Nevada have joined just recently. So it is expanding, and we'd love to get some New York people joining with it too. So
Thank you.
contact me if you're all interested in that.
Can you drop a link in the chat, Charlie?
With ArrayRx or a link for me. I'll give you my
Whichever.
email address. Yeah, I'll do both.
All right, I'll take facilitated privilege and ask the next question. Actually, for one of our members, I'll read the question from Judy Fletcher. And this is a little esoteric, Steve, so it's a little meta.
If I don't know, I will say I don't know.
And I love you for it. I have read, she says, elsewhere that this bill would enable red states to enact regressive state policies for healthcare. How would the benefits of this bill for progressive states offset the damage it could do in the red states?
So that's the Common Dreams article.
Oh.
And my quick statement is it is simply false. It is a false statement that this would allow states to do that. It is in the legislation explicitly that they cannot do something worse than what currently exists. Now, is a state going to go out and break the law, federal law? Sure. I mean, that happens all the time. It is current waivers that already allow states to do worse. And the prime example is things like work requirements and drug testing for being Medicaid eligible that some states have tried to do. The argument that was made in that Common Dreams article flies in the face of the explicit language of the Subucha law as written, and comes frankly from a place of bad faith by folks who are opposed to single payer, state-based single payer in principle.
Which is what we're all up against, trying to get the word out.
You know, if you're for the New York Health Act, then that opposition to Subucha Common Dreams article wasn't just about Subucha, it was about the New York Health Act.
Great, thank you. Pass the word along.
And there is, in my talk, there is the counterpoint article that the One Pair States people published in Common Dreams as the counterpoint to it.
Okay, thank you. Who else has a question for Dr. Steve about the state-based act in Washington or the New York Health Act specifically for New York State? Questions? Well, I'll ask one if somebody doesn't have a question. Steve, about
Carmody does.
Say again?
James Carmody does
I see
in the chat. James Carmody in the chat
James
says he has a
Carmody.
question.
I see it. James, where are you? Oh, I see you. If you unmute, we can get your question. There you go.
Well, I'll read it from the chat. Steve, it said to you in Spanish, also translated to English. ¿Conoces las leyes no aprobadas, Subucha y Naija? Evidentemente, hasta leyes in español, which verbatim would mean, do you know the laws that don't apply Subucha and New York Health Act currently until laws in Spanish? Also, are those 10 over 75% states covering with Medicaid and CHIP?
So I'm not sure I understood the first question. The 10 that are over 95%, that's of their total population, more than 95% are covered. And yes, that includes whatever their Medicaid and CHIP is. So it's states that have, it's progressive states that have aggressively expanded Medicaid eligibility I think Massachusetts, I'm not exactly sure where New York is. It does the 95% nominal coverage, of course, doesn't mean doesn't mean getting healthcare is affordable. It doesn't mean 3/4 of doctors don't take Medicaid, so it doesn't mean you actually have access to healthcare if you're covered and your coverage is Medicare. And my apologies, I don't think I understood the first part of the question.
Essentially, what I'm asking is, are the laws that we're trying to pass as bills available not only in languages like Spanish and also Chinese
Right. So
and
the
is outreach being
advocates,
done in Spanish and
yes. So
Chinese
there is
and
an active,
as well as English?
yes. So 2 weeks ago, this was taken up with the One Pair States meeting. There's a couple of bilingual, actually Spanish first, speakers in the One Pair States group that said they were going to work on translating materials. So at the moment, let me rephrase. At the moment, there's nothing in One Pair States material that's in Spanish or other languages. But there's an active plan to do so, and there is the capacity to do so because on their board of directors, they have some native Spanish speakers. Other languages, no, that I'm aware of for One Pair States. Now, for New York Health Act, we actually have several-year-old versions of flyers in about 15 languages. And I have collected all of them, and I have sent them previously to Melanie. And so we have, not only do we have Spanish, but we have several East and South Asian languages. We have both Arabic and Yiddish. We have numerous languages available for at least the one-page flyer version of the New York Health Act advocacy material. Did that answer your question, James?
Yes, and I'm also wondering, is there a capacity and intention to do outreach in these languages in Spanish and others as well as English?
Yes, I'm a monolingual person who's barely speaking English anymore. But if there's folks out there that can do that work, it is the most needed thing. I agree completely with that. Others here, I know Melanie is interested in working on that. I know that, for example, the last forum PNHP did was specifically on migrant healthcare, and we had speakers that were Spanish language only as part of the panel, and we had translation of both directions. So we're trying.
And there's capacity and intention for Arabic and Yiddish and Chinese and Korean and Japanese and Thai.
Yeah, so we
as
did
well?
have all of those. Not only is there intention, but there was success with the caveat that it was the one-page version, and it's a few years ago. Every language you just mentioned, I believe we have a flyer for.
Okay.
But I can't speak to how much outreach. I mean, we're working, we at PNHP at least are working with the New York Immigration Coalition and Make the Road, which are two immigrant advocacy, social service and health service groups.
Okay, maybe any outreach expanded to, say, the American Jewish Congress or the
I think it's time to move to the next question. I mean, I think NIPAN can address for NIPAN, and if you want to, speak offline, my contact info was in the slides. I'm happy to share again the collection of materials in multiple languages that I've shared previously with Melanie. I'm happy to share it with you directly. I'm happy to share it with NIPAN as all.
Thanks, James, and thanks, Steve, for that. Are there any questions? Any remaining questions? Melanie, by the way, that Steve mentioned, it's Melanie Dorigo. She's the director of the Campaign for New York Health. And if you go to campaignfornewyorkhealth.org, there's a lot of information there available to you. If there are no more questions, we have a couple of minutes left before the end of the hour. I can open it up to Rebecca Street. Again, Steve, thank you for your work ongoing, your enthusiasm. We appreciate it a lot. Rebecca, you want to tell us a little bit about the
The pledge,
yes, right,
Yeah.
the pledge letter.
yes,
Pledge.
the
Yeah, go
pledge.
ahead.
So, I'm a new member, to NIPAN's, single payer steering committee. But when I first joined, Ting, mentioned that perhaps I might work on a pledge, and I know that there was one in 2021, and I looked at that pledge, and that was basically, the format was like a form where you filled in various questions and check boxes. The one that we've come up with is more of a declaration, a personal declaration. Let's see. So I'll just go ahead and read it. I did want to mention one of the things that I thought was really insightful was Julie said that this would, and let me just quote her. This pledge would really help separate who is serious from those who pretend to be just to get our endorsement, and that any elected official who signs it and puts it on their website or newsletter deserves endless praise on social media. So here we go. It begins, and there's a space for the elected official to put her or his name. So, as a proud representative of the great state of New York, I, and the person would sign, pledge to make the well-being of my constituents my #1 priority. Since the concept of well-being is inextricably tied to health, it is unacceptable to me that countless New Yorkers are either underinsured or uninsured. In a democracy, especially a rich democracy like ours, I believe healthcare should not be a privilege for the wealthy, but rather a right for all people. In order to promote this essential right, I am supporting the New York Health Act and will do all in my power to promote its passage, including being a co-sponsor, educating New Yorkers regarding both its excellent coverage and financial viability, and bringing it to a vote. When the New York Health Act is passed, New York will act as a courageous model for the rest of the United States. I am dedicated to being part of this historic event. So we've already started to brainstorm, thank you, a little bit about how we might implement this and really come together and try to do a massive outreach throughout the state, and then have people writing to their elected officials, perhaps even like the get-togethers, people have to write postcards during the elections, but that we would send out information all over the state and try to get that to the officials, and then, really support those officials in any way that we could. And of course, social media is, I'm not on any of it, but most people are, and it's a wonderful tool for doing that. So that's the Health Act.
These letters might also go to every legislator we find,
Right,
anybody in our own district,
right, exactly. That,
everybody
yes,
coming into the windows.
yes, and if we got people to have meetings throughout the state, at their homes, or I remember when I first was participating, I had one at my home. This is pre-pandemic, and one at my church. And so, getting people to have these, again, almost like the postcard writing, where we had their state legislatures, whatever they were, at that particular meeting, and ready for people to put personal notes, address the envelopes, and have them go out at a certain time.
Right, right. So if anybody wants the copy of the pledge letter, excuse me. Copy of the pledge letter is in the chat. And as
I'm
I
going to
lose-
include all that in the email tomorrow also
Perfect.
to
Thank
follow
you.
up.
Thank you. And as I lose my voice and it gets to be 9 o'clock, are there any comments that anybody wants to do to be complete with our conversation tonight? Seeing none, we can declare the meeting adjourned.